you may be able to find some helpful information during the symposium to help you weed through those technical issues. Last year, our exhibitors were throughout the hallways of our venue. This year, we are bringing information to you on our symposium page. I urge you to review that information during the break and lunchtime periods. There's a lot of helpful information that can be found there and resources that you can use for a later date. During tomorrow's general announcements, I will address the issues related to continuing ed credits and how to complete that evaluation. However, it's very important for those of you who are seeking continuing ed credits that during the sessions, there will be poll questions. It's very important that you answer those poll questions because that will help us determine to ensure that folks are still attending the session and that we are able to provide the continuing ed credits to you. So answering those poll questions will be very important. Finally, I want to remind you all that we navigate the symposium together. We are really in all of this together. I almost can guarantee that we're going to have some technical difficulties at times. That's how technology goes. Please be patient with us. We're all working very hard so that those things don't happen. And when they do, we will navigate them together and we will just persevere and handle things as they come up. And now it is my absolute pleasure to introduce to you Jerry Daly from the Liberty Mid-Atlantic High Intensity Drug Trafficking Area Program and my co-chair for this symposium. Thank you so much, Jerry.
Good morning, Kim, and good morning and welcome to everyone. Thank you so much for being here today. I am really delighted that we can, once again, in conjunction with Secretary Jen Smith and her team at DDAP, continue this process that we began last year. This is our second Pennsylvania Psychostimulant Symposium, and the tremendous interest it has generated is really gratifying. Clearly, holding this in a virtual format is different, and there's going to be unfortunately no opportunities to meet individuals during the breaks, over lunch, and after hours. But we are delighted that about 500 people or so have registered as participants. For those not so familiar with the HIDA program in Pennsylvania, we are one of two HIDA regions, ours being in the southeastern counties around Philadelphia, and the other, the Ohio HIDA, in the 4 counties in the southwestern portion of this Commonwealth. I'm happy that our colleagues from the Ohio HIDA were able to join us for this event as well. Although most of our investigative and enforcement efforts are focused on these designated counties, we work across the Commonwealth with our colleagues from the other HIDAs, but most importantly, in the HIDA program overdose response strategy, a truly unique partnership with the Centers for Disease Control that is now in its 5th year. It has grown from a relatively small, single-issue effort focused on heroin to one that's nationwide and includes all drugs of misuse, connecting public safety and public health strategies to reduce overdose incidents, sharing data and information about drug trafficking and drug use patterns, and collaborating on novel interventions with state and local government agencies and communities to educate and inform evidence-based approaches that aid in reducing drug use and the harms that accompany their use. We are also very pleased to have the support of the National Emerging Threat Initiative, NETI for short, another nationwide HIDA initiative that provides current intelligence on novel and trending psychoactive substances finding their way into our communities. NETI tracks indicators such as the diversion of prescription pharmaceuticals, surges in illicit drugs, and the introduction of new and dangerous substances previously not known or widely observed. Their work, along with that of partner agencies like DEA, who recently published a report on illicit stimulant availability in Pennsylvania, show clearly the increasing prevalence of stimulants in the illicit drug marketplace and are manifesting as a major source of concern in just about all corners of the Commonwealth. As the maps on screen note, significant year-over-year increases in both cocaine and methamphetamine seizures around Pennsylvania point to what some call the fourth wave of the opioid crisis, the polydrug phase. And deaths involving stimulants are on the rise as well. In 2019, a third of all overdose deaths show the presence of cocaine, though only about 6% of cocaine by itself. Meth was present in about 10% of all deaths, but just 2% alone. But the combination of an opioid with either of these stimulants greatly increases the likelihood of a fatal overdose. Over the next 2 days, people much smarter than me will present data on the rising threat of stimulant use. Clearly, the additional complexities of psychostimulants, used alone or in combination with opioids, pose new challenges for all of us with roles in reducing their adverse impacts. Potential aggression associated with their use can endanger first responders and emergency medical personnel. There is no overdose reversal drug like naloxone for acute cocaine and methamphetamine toxicity. While there's been many improvements in the quality and availability of treatment for opioid use disorders, particularly with respect to medication-assisted treatments, there are no comparable MATs presently accepted as effective, and non-medical therapies have proven only to be marginally successful. And drug misuse prevention programs need to recognize this new reality as well, which is what brings us together virtually these next 2 days. So I want to say thank you for being here, for being willing to learn about, understand, and respond to the many dimensions of this problem, and for serving in the roles that you play in addressing the stimulant use disorders and curbing the spread of these drugs in Pennsylvania. I also want to thank my co-chair for this Symposium Planning Committee, Kim Coleman, and her team from DDAP, as well as my team from the Liberty Mid-Atlantic HIDA, who have been working for 9 months to bring this all together. You deserve a round of applause from all participants, but you'll have to settle for some kudos from me for the time being. I hope all of you will find the next 2 days a valuable investment of your time, and I wish you all good things as we near the end of this most unforgettable year. Be well, do well, and stay well.
Kim, I think your microphone is muted.
Thank you, Kayla. Thank you so much, Jerry. Those are one of the technical issues that I know are going to happen today. Just didn't think I would be the first one. But I just want to thank Jerry Daly at HIDA. Right now, it is my pleasure to introduce the Secretary of the Pennsylvania Department of Drug and Alcohol Programs, Secretary Jennifer Smith.
Thank you, Kim. I thought for sure I would be the first one to forget to unmute myself or forget to turn the camera on, one of the two. So I'm glad you got it out of the way for me. Good morning, everyone. So good to see you virtually, or at least see your names. I want to thank all of the attendees for taking time out of their schedule to join us. Even if you're only able to join for bits and pieces, just thankful that you're able to take that opportunity, and maybe you'll have the chance to check out some of the recorded sessions afterwards if you're not able to join us live. I also want to thank all of our speakers. We've got a tremendous lineup over the next 2 days, and these are folks who have taken time out of their schedules to prepare for this, to present it, and likely answer some follow-up questions that will come from the symposium. And they're doing it because they believe in the work that we're doing and not because they're getting paid to do it. And that's something that's so wonderful about the people that work in our field, is that we all care so much about educating people and doing the best that we can to know the most information and follow what the data is telling us. And that's just so tremendously important. And I very much appreciate that. I also want to be sure to give a very special thank you to Kim Coleman, to the folks at VDAP who are making this possible from a technology standpoint, Debbie Smith, who helped with all of the planning and logistics and kept us adhering to our deadlines. And then, of course, Jerry. I love you, Jerry. I'm so sad that we're not able to do this in person, and I'm not able to get a nice big Jerry Daly hug. But thank you so much for your support of this initiative and for the way that you've worked with our department so well over the last many years. And to your team, thank you, thank you, thank you. Lots of time and effort has gone into not just planning this symposium, but really having thoughtful conversations with our department, excuse me, and with the Wolf administration more broadly about psychostimulants, about heroin, about opioids, any topic that seems to cross our path. You all are always willing to be at the table and to offer really excellent advice and input and your willingness to help. So thank you so much, Haida. We really appreciate the partnership. So I'm going to make a statement here that's pretty obvious, I think. 2020 has been a difficult year. Lots has happened during this calendar year. And I think if we had all been told at the symposium last year that you would have to go to the grocery store wearing a mask, that you wouldn't be able to celebrate Thanksgiving with your loved ones, we would have looked at each other like, you're crazy. You know, no way, that's not going to happen. But here we are. Here we are navigating a world filled with COVID-19 uncertainties, difficulties and disappointments. And at the same time, navigating a continued opioid crisis where we're seeing deaths starting to rise again. And I'm going to talk about that very shortly here. So it would have been easy for us to say, you know what, stimulants, they're not our number one priority right now. You know, let's focus on the pandemic. Let's focus on the increase in the opioid overdoses. Let's set that psychostimulant stuff aside for now. But I think you'll see in the slides that I'm going to share with you here shortly, and from what Jerry shared just moments ago, there really is a need to continue focusing on this topic. And even though it would have been the easy thing to do to say, let's just pick that up again next year, we're picking it up this year because it is truly an important topic. And it's important for all of you to understand what the data is showing us. So tech folks, if you wouldn't mind loading my presentation here. And while those slides are coming up, the purpose of what I have to share with you today is to really set the stage from a high-level data perspective using various different sources to support the notion that stimulant usage is continuing to rise here in Pennsylvania. And that's why we need to be here today. That's why we need to continue to chip away at finding the best ways to prevent, to intervene, to treat, and then to support people in recovery from stimulant use disorder. So let's start things off here by taking a look at some of the data. So right here, you've got a chart that shows fatal overdoses. And it goes back as far as 2014. You can see that the trend here is a really steady climb up to the peak that we hit in Pennsylvania in 2017. And that peak was at a little over 5,400 deaths. And then thankfully, in 2018, we saw about an 18% decline in those overdose deaths. And that was thanks to so many different efforts that we were working on to address preventing things, to address opening access to treatment, just so many different initiatives contributed to that decline. And then into 2019, you see, if you look really, really closely, you can see that the line is still trending downward, but it's trending downward at a much slower pace there. So the numbers from 14 to 18 on this slide are pulled from the DEA reports, and that's noted at the bottom of the slide. The 2019 number is pulled from the Pennsylvania Department of Health. You're actually going to hear tomorrow a little bit from some folks in the Department of Health. So there are two different sources, but the data is fairly closely aligned. So from 2018 to 2019, assuming these numbers are accurate that are reported here, and they should be close to accurate, you would see about another 3% decline between 18 and 19. What we don't show on here is 2020. And I think most of you recognize where this line is going to head if I add 2020 to the graph. It is absolutely going to increase again. And those overdoses are not just opioid overdoses. That contributes many different substances to those overdoses. So you can see where we were a few years ago, saw some success in 18 and 19. Unfortunately, 2020 is going to change that trend for us. Switching gears just a little bit, and Jerry talked about this. He actually presented some data in his slides earlier. This is drug seizure data as reported by the DEA in Pennsylvania. And you can see if you look at the color coding, I know it's tiny on the slides, but the methamphetamine line item is the brown color. So if you start at the bottom of that bar chart, it's the fourth color up. So pink, blue, purple, and then brown. That brown is methamphetamine. And if you look at that, the size of that brown bar, the thickness, 17 to 18 to 19, you see the thickness of that bar continuing to increase. So again, this was seizures as reported by the DEA. Now we're going to take a look at seizures reported by the Pennsylvania State Police. And folks, if you don't mind, we put a polling question up asking whether or not you participated in last year's symposium. So while you're taking a look at the charts, if you don't mind responding to that, we'd love to know how many of you are returning to us from last year and how many folks are new. So this is Pennsylvania State Police seizures, and this is data from 2014 through 2020 as of November 23rd. So, still a little bit of time in 2020 yet, but as of what we had the end of November, basically. And you see the two lines, cocaine is the blue line and methamphetamine is the red line. So really, if you take a look at that methamphetamine line, you will see that starting in 2015, it has really been a pretty steady increase in terms of what we are seeing with seizures from the Pennsylvania State Police. Also interesting, and why we included cocaine on here as well, look at the jumps that you see in that blue line. So a really big spike in 2015, and then a drop in 16, a steady climb back up in 18, and so far been continuing to decline through 2020. So it's very interesting the differences in those two substances. Cocaine is very sharp upward and downward trends, and methamphetamine has been a slow, steady climb. So again, reiterating that in terms of DEA seizures in Pennsylvania and Pennsylvania State Police seizures, we are seeing increases in methamphetamine. So the other thing I want to share, good polling. Looks like we're getting a good response here. We've got about 73% of our folks are returning from last year. That's excellent. We'll take that to mean that you thought it was worthwhile information, and hopefully you hear some really good new information this time around. And for those of you who are new to the symposium, thanks so much for joining us. Hopefully you'll take away some really great bits of information. So thanks, polling folks, for sharing that for us. That's helpful information. What you're looking at now on this slide is hotline data. So this is the hotline that Pennsylvania established for substance use disorder, and it is available 24 hours a day, 7 days a week, 365 days a year. It's the 1-800-662-HELP number. It's the national hotline number, but based on your area code, it routes to the appropriate state that you're calling from. And so here in Pennsylvania, we have a call center that supports that hotline. And the data you're looking at here are calls by quarter from Q2 of 2018. So that would be starting in March of 2018 through Q3 of 2020. So that would be through the end of September of this year. And we broke these out. I want you to look at the categories here. Now, I do apologize that the labels are just reversed on those top two there. So the top line on the graph is actually the opioid line. And then the next line down, which is the really dark colored blue line, that is alcohol. The red line is your stimulants. And then the light blue is all other substances. So the reason I wanted you to look at this is this opioid line continues to top the charts, right? And that opioid line includes both prescription as well as illicit opioids. So that's all opioids. And you see that the number of calls for opioids continues to really dominate the calls. And you'll see that starting in Q2 of 2020, right around the pandemic, we started to see a really big spike in those calls. So what also happened at that time period, in conjunction with the pandemic, was another push of our hotline information through some media channels. So if you look at kind of all the lines look like they start increasing right around that Q2. That's no surprise because we did some media push to make sure that folks were aware that that number was available. So you can see that stimulant line is really rising there. This is the same data set, but you're looking at it a little bit differently. This is the total of all of those calls. And on this chart, we broke out heroin from the rest of the opiates. So now it looks like alcohol is the highest. That's because we split out the opioids and heroin. And the reason I split it out on this chart was because I wanted you to see just how close the number of calls for heroin is to the number of calls for stimulants. Look how close those numbers are, just within a couple hundred calls over that 2.5-year period of time. So wanted you to know, certainly calls are on the rise related to stimulants. And this chart shows the percentage of treatment admissions where stimulants were recorded as the primary drug. So if you look on the left in 2007-8, you'll see that most of the state is that really kind of light color blue or light gray. And that means that it was a very low percentage of admissions that were as a result of stimulant usage. Then fast forward 10 years later, 17, 18, and you see that basically the whole state has become a little bit darker shade of blue. And then there are some counties there that have really popped out. So for example, you see Schuylkill County there went from 0.58% of admissions to 29%. So more than a quarter, almost a third of their treatment admissions that year were for stimulants being listed as the primary drug of choice. And then up in that northeast corner, that's Susquehanna County, that went from 1.3% to 27.8%. So another really big jump. And the data you're looking at here is for publicly funded clients. So I just want to be really clear about that. This does not include patients who are insured through private insurance, and it does not include Medicaid data. So these are just admissions to treatment for folks that we at DDAP fund. We consider them under or uninsured patients. I would say, though, that the trend is fairly representative of what you would see across all funding streams. And then stick with me on this one, because this is a really cool data set. This is showing on the far left how many publicly funded admissions there were in 2018. So you see that 28,598 number. The next column over shows what they reported as their primary substance. So you see opioids kind of dominates that list, and stimulants is about halfway down the screen. As you continue headed right on the chart, so that middle column, this shows that for folks who reported opioids as their primary substance, how many of them reported using only opioids versus using another substance as well. And if they reported another substance, then you go all the way to the right and see what that other substance was. And for the opioid category, look all the way to the right and look how large that category is for the polysubstance use, including stimulants. That's a big grouping, folks. And so I wanted to show you all of this data to just say that all of these things together show there's more substances in the markets. We're seeing higher calls. We're seeing more admissions to treatment. And I think when you combine all that data together, you know it means that the need is growing. And really the justification for this symposium proves itself right there. The last couple things I wanted to cover this morning was to talk about where we've come from last year. So in terms of funding, last year we had access, and the last couple years, we've had access to some wonderful grant dollars from the federal government called the State Opioid Response Grant. And those dollars were tremendously helpful to states in addressing the opioid crisis. The only downfall was that they were opioid specific. And that meant that we really couldn't use those dollars to focus on things related to stimulants. So even though here in Pennsylvania and some other states, we saw the need increasing for those substances, we just couldn't use the funding to support it. Where we've come since last year is that, thank you to Congress, they have amended the language for those opioid response grants, and we are now permitted to use those dollars to address stimulant misuse as well. So that's a really huge change for us that has been beneficial both at the state and the local levels. And you see listed there a couple of different ways in which we're starting to use the funding to address stimulant misuse. And then just very quickly, some things we've done with training. At DDAP, we've expanded some of our efforts to include the matrix model. The matrix model is a research-based approach to treating individuals with SUD, including folks who are addicted to stimulants. And it uses relapse prevention techniques and self-help programs as well as drug monitoring. And you can see there we've rolled that out in 9 counties. We've trained over 150 clinicians and over 50 clinical supervisors have completed the more advanced course. So still working to roll that out, but that's a really important piece to addressing stimulant use disorder. And then contingency management, which is a behavioral therapy that provides rewards for positive behavior. So you can see there we've also been rolling that out and encouraging its use. And last but not least, some national training efforts are underway. There's a core curriculum being developed that actually addresses specifically stimulants and the impact on their brain and behavior. So just some things to consider in terms of where we've come since last year. We've still got a lot of work to do though. And thank you all for being here today. Very quickly, there's my contact information. And at this point, I will turn it over to our moderator for the remainder of this plenary session. Thanks, everyone.
Thank you very, very much, Secretary Smith. Good to see you today. Hi, everybody. My name is Mary Jones, and I'm acting as your moderator until 10 o'clock this morning. Before I introduce our next speaker, who is Dr. Richard Rawson, I need to let everyone know that we do not anticipate having time at the end of his presentation for a question and answer session. I encourage you to submit your questions via the Q&A pod, which is showing at the bottom right of your screen. We'll be capturing all the questions that come in, and the answers will be provided to everybody. Also, as a reminder, during this session, you will see a few polling questions come in. They're going to pop up in that lower left part of your screen where the previous one did during Secretary Smith's presentation. We want everyone to answer those polling questions. It allows us to interact virtually through you, the audience, and your participation. And for those of you that are earning continuing education credits today, you must answer those questions as they'll be used to confirm your attendance. Not answering the questions could decrease the number of continuing education hours that you receive. Now, I'd like to introduce Dr. Richard Rawson. Dr. Rawson is a research professor at the Vermont Center for Behavior and Health at the University of Vermont and Professor Emeritus for the Department of Psychiatry and Biobehavioral Sciences at the University of California. Dr. Rawson, welcome.
Can you hear me okay, Mary?
Yes, we can hear you
I
now,
can,
Dr. Rawson.
yes. Yep.
Great.
Yep.
Okay. Yeah, thanks very much. I was interested to hear the Secretary's review of the data in Pennsylvania. I haven't heard that. I'm going to provide a bit of an overview of the national situation, and then this is going to be a pretty quick run through a lot of information. That's why we asked that you could send the questions in, and I'll answer them in writing and send the answers back to everyone. Because I thought the material I have, there's a lot of new material on stimulants, and I wanted to give you just some idea of the breadth of the information and finish up with what we currently know about treatment. I almost 40 years at UCLA, started to see lots of stimulant users in the early 1980s, predominantly cocaine users. About a decade later, started to see a lot of methamphetamine users, and for the balance of my time till about 2015, we did a lot of work with methamphetamine, with NIDA grants, and a variety of other kinds of research and training projects. I see the people are answering the poll question. That's good. And I'm just gonna now that you're thinking about it, I've got you thinking about it, that's good, but I'll just give you the answer. The answer is all of the above. All of these things are of importance. One of the ones that I hopefully will be able to spend a little time is hyperthermia, which is high temperatures. When individuals have methamphetamine overdose, one of the symptoms that often kills them is a temperature that goes to 107 or 108 degrees, and that is the cause of death. And EMTs now have to have the capability of bringing down people's temperature with these overdoses. They're obviously very skilled with the use of naloxone, but now we have this temperature reduction strategy that's necessary in overdose response. So let me start. Mary, next slide. Next slide. I'm going to make an attempt to use person-first language. I think that's really a very positive step in the field, that we're moving away from using terms like addicts and users and talking about these as people, as people first who have substance use disorders. I do have to say, though, I'm an old dog and it's hard to teach me new tricks, and you may hear my old terminology slipping back in, and I apologize for that. I'm trying. Next slide. This is what the product, the methamphetamine, is that we're currently seeing on the street. Back during my early days when you could buy it in powder and people snorted it, no longer. It's almost all now in this crystal form that we started to see, and it was called ice in the early 90s. Next slide. You're all aware of, if you watched Breaking Bad, of the methamphetamine problem we saw in the 90s and early 2000s. This was driven by ephedrine and pseudoephedrine based methamphetamine that was manufactured in home labs all over the country, mostly in the West and Midwest and increasingly the South. It never really made it in large amounts into the Northeast during this earlier epidemic. Next slide. In 2005, Congress passed the Combat Methamphetamine Act, and one of the things it did was put pseudoephedrine products behind the counter or limit the amount you can buy. And that really had a major impact on reducing the availability of methamphetamine. Next slide. You can see we saw a dramatic drop off in lab incidents, peaked in about 2003. They were taking down about 25,000 labs a year, and now it's down to about almost 10% of that in 2017, and that number's probably continued to go down. And the reason isn't because the demand for methamphetamine has gone down. The reason is the supply coming in from Mexico from the cartels is increased dramatically. Next slide. The new methamphetamine is manufactured with a process called P2P, which makes the methamphetamine more lethal and more potent. As you'll see, some of the increase in overdose deaths associated with methamphetamine is, there's a lot of assumption that most of those deaths are because fentanyl is also included in virtually all the stimulants coming into the US now. But it's actually with methamphetamine, we're seeing deaths from methamphetamine, that the deaths are because this drug is more potent and more deadly. And there's huge amounts of it coming in. Beginning in about 2014, it started, much of it, and now most of it in some parts of the country has fentanyl. Here in Vermont, I'm in Vermont right now, we don't see much methamphetamine here yet. We see a lot of cocaine, and virtually all the cocaine samples have fentanyl in them. So it's really become sort of universal that all the drugs coming in from the cartels contain fentanyl. Most recently, in June of this year, we saw another drug, isotonitazine, referred to as ISO, which is another opioid that was showing up in the Midwest and Chicago and some areas around there as another potential opioid that would be used with the way fentanyl is now. I think the cartels got a little spooked during the March period of time when they couldn't get fentanyl from China because Wuhan, China is one of the major supply centers of fentanyl. And obviously that's where the COVID problem started, and there was nothing going in or out of Wuhan for a few months. And so they're interested in diversifying their opioid supply options, and this may be one that we start to see in the future. Next slide. This is, as the secretary talked about, the data from the state of Pennsylvania. These are the national data, and if you look at the blue line, the top line is prescription opioid deaths, and that was really the first wave of the opioid crisis in the United States, was that increasing rate of prescription opioid deaths from 99 through about 2010 or so. Beginning in 2010, you started to see an increase in the red line, which is heroin in 2010, you see an increase in the purple line, which is heroin-related deaths, followed by the green line, which is fentanyl-related deaths, and then the red line, which is stimulant-related deaths. So people are now talking about stimulants as the fourth wave of this crisis. And the stimulant crisis obviously includes cocaine, methamphetamine. We're starting to see a little bit more prescription stimulants as part of the package, but with the cocaine and methamphetamine, they all have fentanyl in them as well. Next slide. Next slide. Oh, you can click through these. Yep. So overdose deaths involving stimulants, about half of the stimulant-involved overdose deaths involved opioids, and that was in 2017. That proportion has gone up in the last couple of years. And we're seeing in the population of opioid users, I'm doing a lot of work now in West Virginia, where they have a huge opioid problem. And there, many of the opioid users are adding methamphetamine to the package of drugs they're taking. And so you're seeing the mixing of these drugs back and forth. The idea that we have exclusive opioid users or exclusive stimulant users is increasingly rare. The more we really are now seeing really this salad of these mixtures of opioids and stimulants, of course, in cannabis and alcohol and the rest, but these are the ones that are really involved in driving the death rates. Next slide. I wanted to make mention of this. The stimulant overdose death problem is mixed depending upon the population you're looking at. The left-hand bar represents the age-adjusted deaths per 100,000 of people who died from cocaine, and the dark bar, methamphetamine, the light blue bar. And you see in non-Hispanic whites, it's roughly equivalent. The same number of people dying from cocaine as methamphetamine, which, by the way, I think deserves mention. With the current publicity about things, you would think that methamphetamine is the only thing that's now on the horizon. Cocaine is still there and is killing a lot of people. If you look at the middle set of bars, that's American Indian Alaskan Natives. In those communities, methamphetamine is the greatest killer. It even outshadows opioid deaths. Methamphetamine has been a big problem on reservations and in the other communities of Native Americans. And methamphetamine, certainly drives the overdose death rate. The second set of bars, though, I think is really most notable. That's in non-Hispanic blacks. And in the African American community, cocaine is still driving the overdose death problem. And I think that's particularly important in urban eastern centers, as you have in Pennsylvania. I got a call from a state director from a northeastern state who was saying he was very concerned that they're seeing methamphetamine and they really wanted to develop evidence-based treatment for methamphetamine. And so what could they be doing? And I said, well, I think that's really good, but you have some large cities in your state. Are you using evidence-based treatment for your cocaine, individuals with cocaine dependence? And he sort of was like, well, we really haven't been looking at that. And I would just urge you to make sure that this stimulant, the current epidemic is not a methamphetamine one, it's a stimulant problem. And it manifests itself with both of these drugs. And some would argue in some rural northeastern parts, prescription stimulants being part of the package increasingly. Next slide. Next slide. These are graphs of cocaine-related deaths. The left-hand panel, the top blue line is total number of cocaine-related deaths, and this runs through 2017. As you can see, a sharp increase. And the two lines below it in the left-hand panel are those with fentanyl or other opioids in them. The right-hand panel, again, is the primary death curve, the top one, and the lower lines are those without opioids. So with cocaine, the deaths really are being driven by the opioids that are in them, either heroin or more commonly fentanyl now. Next slide. ATS, or methamphetamine, that stands for amphetamine type stimulants, which is how the UN refers to this category. You can see, again, you see a very sharp increase beginning at about 2015 of deaths associated with methamphetamine. The left-hand panel is with opioids. You can see it's lower than it was with cocaine. And if you look at the right-hand panel, which is methamphetamine deaths without opioids, those have increased dramatically. So with methamphetamine, the deaths are being driven by the methamphetamine itself. So as you're seeing more methamphetamine, people doing working in emergency departments and in ambulances really need to develop the capacity to respond to stimulant overdose, which is very different than opioid overdose. And now, of course, many of them are both. So it's become much more challenging for those folks. Next slide. The very simple statistic, amphetamine users had a 6-fold elevated rate of mortality compared to their non-methamphetamine using peers. Men had about twice the rate of death compared to women. Most common causes of death: drug poisoning or overdose, accidental injury, suicide, and cardiovascular disease. Next slide. And this is important. I know in Pennsylvania you've had a huge effort to increase the use of buprenorphine and methadone, but a lot of the work has been done with buprenorphine to address this opioid crisis we've had. And now we're seeing the increase in methamphetamine and cocaine is having some detrimental effects on that effort. Next slide. These are data from the state of Washington. This is 800 new admissions into treatment. About 2/3 of the people being admitted into treatment were just using opioids, and about 1/3 were using opioids and methamphetamine. Next slide. These are the retention rates on buprenorphine. These are retention curves. The top line are those individuals who were just using opioids at the initiation of treatment. And as you can see, if you go out to 800 days, close to 50% of the patients on buprenorphine are still in treatment, which is, I think, quite excellent that they're getting that kind of retention. I mean, we'd like to see it higher, but 50% for 2.5 years isn't bad. The story, though, is the lower line, the third who were using methamphetamine at admission. There you see in the first 100 days a rapid drop-off. Now, that probably is a combination of two things. One, that individuals who are using methamphetamine are just too disorganized, and two, their functioning is so impaired that they just can't keep it together enough to go and get their buprenorphine and stay in treatment. The other more troubling issue is that some of those folks that quote unquote dropped out in the first 100 days didn't drop out, but they were kicked out of treatment by their prescribers, who felt that if they were going to continue to use methamphetamine, they were not willing to continue to prescribe them buprenorphine. Now, I don't have time to go into a whole lot about what the answer to that is, other than to say, don't kick people out of treatment. Taking people off buprenorphine, whether they're using methamphetamine or not, increases their risk of death by about 10-fold. So if you've got a patient and they're on buprenorphine, and they happen to be giving you methamphetamine positive urines, certainly it requires attention. It requires them to see the behavioral health person. You may have to see them more often, talk to them more, but don't kick them out of treatment. Kicking people out of treatment at this point, I think, is puts you at great liability for lawsuits. Taking people off buprenorphine involuntarily is really, I think, going to rapidly be considered malpractice. Next slide. Okay, here's some new data, and I'm going to go through this quickly, but I just wanted to give you a quick tour of some of what we know about methamphetamine effects. Next slide. Martin Paulus just published a paper earlier this year in JAMA Psychiatry. It's a great review of neurobiology, clinical presentation, and well, I didn't agree with his treatment section, but the other two I think are really good. Next slide. Methamphetamine affects the brain. All the work that was done in the late 90s and early 2000s, looking at PET scan data and MRI data and all sorts of other neurobiology data, makes it really clear that methamphetamine is really toxic to the brain. It affects the dopamine system and a variety of other areas. And when you're seeing individuals who've been using methamphetamine, they really have symptoms that are consistent with a degenerative nervous system disease. They've damaged their brain and their areas of it are not functioning properly. Next slide. You see cognitive effects, both short-term and even long-term. And even people with 4 to 6 months of abstinence still have some comprehension and other cognitive deficits that. So you're really dealing, when you're dealing with this patient population, you have to think that this is really a population that you need to treat in many ways like you treat patients with traumatic brain injury. Next slide. And you see in Martin's review of the literature, about 2/3 of those individuals who come in using meth show this cognitive impairment. And the impairment is greater with older patients, with those who've used longer durations, they've used more years. I missed one here, which is the route of administration. If they inject methamphetamine, everything is worse in every domain. Their prognosis is worse, their cognitive effects are worse, their medical problems are worse, their life expectancy is shorter. So this is if you have injectors, you really have people who are engaging in highly dangerous behavior, and those who use more often. Next slide. Methamphetamine use has been associated with violence. This reviews 28 studies. There's about a 2-fold increase in violence compared to incidents with people with other substance use disorders, and it's almost always occurs when they're psychotic. And most methamphetamine users will experience periods of psychosis during their meth use. It's both driven by the drug effects themselves and by sleep deprivation, because they often go days and days without sleep, and they become psychotic. And when they're psychotic, they have a higher propensity to violence. Next slide. So for those of you treating individuals who use meth, when they're psychotic, you have to have a protocol for talking them down and not being confrontational and talking with a softer voice and getting them into a room with less bright lights and getting some emergency help. This is some data that's now really beginning to get a lot more attention. The effects of methamphetamine on the brain, stroke and cardiovascular disease, heart attack. And we're seeing this in a whole bunch of new studies. Most of it's been with young men, but of course it's also true with young women. But this is really quite dramatic to see individuals in their 30s and 40s having strokes and having pulmonary hypertension, cardiac arrhythmia, and the like. Next slide. When I was doing a lot of treatment in the 80s and 90s and I ran the Matrix clinic and wrote the Matrix model, And we had very minimal amount of medical services as part of our treatment, because most of the stimulant users came in and they were, they didn't have severe withdrawal symptoms. And so we would get them in and do some motivational interviewing and get them into treatment. And if they weren't psychotic, we would start them right into treatment, really without much of any medical exam. You really can't do that anymore. Methamphetamine and cocaine and the fentanyl they're involved with produce substantial medical effects, and the patients entering treatment for stimulant use disorder clearly need to have a physical exam, if possible an EKG, but certainly have somebody listen to their heart and lungs as part of their admission procedure. This gives you some data on the strokes. There's different kinds of strokes. If you inject, you're more likely to have a brain hemorrhage, that is a blood vessel bursting in your brain. If you're smoking or snorting, you're more likely to have ischemic strokes, that is the blood vessels being blocked and having that kind of a stroke. Regardless, lots of strokes in this population. Next slide. Again, people treating individuals who use methamphetamine need to know what the signs and symptoms of strokes are, because this is not rare. This happens, the rates are increasing as methamphetamine availability and use go up. And as people start increasingly injecting, you're going to see more of this. Next slide. Current data on stimulant use in pregnancy. Next slide. This is a great article. I highly recommend it for those of you who work with women and specifically pregnant women, because it does a great review of the literature on this, and it's very current, 2019. Next slide. Meta-analysis of 31 studies with cocaine use during pregnancy found that there's increased risk of preterm delivery, low birth weight, small for gestational age, and reduced, that's with cocaine. 8 studies with methamphetamine, earlier gestational age at delivery, lower birth weight, smaller head circumference. Individuals with prenatal exposure to methamphetamine, so if you're starting to see a lot of pregnant women coming in to deliver babies and they're they have methamphetamine on board, the baby is more likely to have, the neonate is more likely to have a withdrawal syndrome of jitteriness, drowsiness, and significantly respiratory depression. And both of these drugs are excreted in breast milk, so if the women continue to use post-delivery, care needs to be taken, and breastfeeding is contraindicated. Next slide. Follow-up, Krista Roth from the University of Hawaii and a group of us did this study. 204 methamphetamine exposed babies compared to 208 unexposed. At 3 years, heavy prenatal methamphetamine use was associated with higher rates of anxiety and depression and attention problems in the kids. At 7.5 years, methamphetamine exposed children had poorer cognitive function. We did a study with 4-year-olds in Southern California. We found substantial verbal learning differences. That is, the babies born to mothers who had used methamphetamine during their pregnancy seemed to have more difficulty acquiring language and using their verbal skills. Next slide. This is an earlier slide by Nora Volkow on, there's a lot more available now. I don't really have time to go into it, but clearly, as the secretary mentioned, the COVID pandemic has dramatically made things worse among our patient population. If people in our population, the patients using stimulants and opioids, become infected with COVID, they're more likely to develop a severe course because they have, these are significant complications. Their breathing system, their cardiovascular system are affected. So that's one thing. And the fact that COVID has caused all these changes in our social behavior, lots more isolation, stress, financial problems, all of those things have led to an increase in not just stimulants, but all substance use. Next slide. Clinical challenges, next slide. If most of you have done your careers in the last 20 years and you've spent them working with, exclusively in the last 20 years, you may not have seen a lot of stimulant-dependent individuals, but it's very different than opioids. Stimulants, the presentation, the syndrome is very different. I mean, with opioids, the whole ball game in many cases, to a large degree, is withdrawal. They don't want to go into withdrawal. They're freaked out about avoiding withdrawal. They'll steal TVs to avoid withdrawal. They'll do whatever they need to do to get their next dose. And that anxiety about withdrawal really drives a lot of their drug-seeking behavior. Not true with stimulant use. Not that they don't have some of that, but it's not nearly as big a centerpiece for their addiction as with opioid users. Part of what the issue is in working with this population, those who are using stimulants, is they often don't see that they're addicted. They often don't view themselves as having an addiction because they can stop and start. They don't have to use every day. They can use episodically. And so if they don't view themselves as being addicted, they're not really thrilled about the idea of getting treatment and stopping. So the ambivalence is much more severe. And so a lot of the motivational stuff really is key in getting this population into treatment. Impulsivity and poor judgment, cognitive impairment and poor memory. We've talked about those. Next slide. Anhedonia, that's really the hallmark of early recovery with individuals who've used stimulants. This sort of everything feels blah, life sucks. If this is the way it feels to be sober, I can't live the rest of my life like this. All of that is anhedonia. We thought, when we first started seeing these patients, we thought it was depression, but it's not depression, it's anhedonia. And antidepressants really don't work on to address this very well. Paranoia, you see a lot of. Even patients who are not psychotic often have subpsychotic paranoia. They're very suspicious. It's difficult to engage them because they're worried somebody's listening to them in the next room. So a lot of that is driven by the ongoing persistent methamphetamine effects. Hypersexuality when using, hyposexuality, and some sexual dysfunction when they're not using, which is a huge issue for many people and needs to be addressed in treatment. Violence, I've mentioned. The sort of the hub of the stimulant addiction syndrome is this triggering phenomenon where they get triggered, some external or internal cue that's associated with their past use, triggers, causes a release of dopamine in their brain, and all of a sudden all they can't think about is getting drugs. And so that's the equivalent of the opioid withdrawal mechanism. And you end up with people who are very challenging to keep in treatment. Next slide. And keeping them in treatment, retention is the ball game. This gives you some data. This is a very recent article, meta-analysis of 151 studies where they looked at dropout rates. Next slide. For individuals, the overall rate of dropout, that is in the first 90 days, we're talking about a discontinuation of treatment in the first 90 days. Overall, about a third drop out of treatment. And you see different categories, but next slide. You look at it by drug category, about a quarter of opioid users drop out of treatment. Now that's relatively low because of we have buprenorphine, we have methadone, we have medications that address their withdrawal, and that's really helpful in keeping them in treatment. Tobacco, alcohol, you see, is about a quarter. Cocaine and methamphetamine is over 50% drop out in the first 90 days. So individuals with stimulant use disorder, retention is the real issue of treatment. you can have the world's best program with all the bells and whistles, but if you can't keep people in treatment, you're not going to produce much of any benefit to their outcomes. Next slide. Next slide. And I mean, part of the reason isn't just because of the drug effect. It's that the treatment for individuals with stimulant, we don't have a buprenorphine, we don't have a methadone for treating those folks. So they can't walk in the door and immediately get a treatment that makes them feel better. And it's part of the reason why this is a challenging population to treat. Next slide. These are some of the categories of individuals who should be considered for intensive treatment. Those who inject and those who use daily are those frequent users, the ones who use every day, and those who inject. Those folks have poorer prognosis, generally need a higher level of care. And then you see some of the other categories of patients who are particularly challenging or who have particular needs. The last group, those individuals in medication treatment for opioid use disorder, are a group that's real. I'm getting a lot of requests for what do we do about these patients on buprenorphine that are using methamphetamine? And they're now injecting again. It's really damaging their treatment. So those are some of the populations. Next slide. Clinical, next slide. I mentioned this whole hypothermia thing of overdose response to people who overdose. Next slide. This was just published. A couple of case studies. This was a 21-year-old unresponsive after ingesting methamphetamine, had a temperature of almost 108 degrees. They used the standard cooling strategies, which are bags of ice and cooling blankets. And after 46 minutes, the temperature was still almost 105. They then put the patient into a body bag filled with an ice slurry. I don't know if they had a ice slurry machine with them or what, but it dropped the temperature to 97 degrees very quickly. Next slide. This second case that they have, next slide. They went right to the body bag strategy. This guy had a 107 temperature. They put him into the body bag with the ice slurry, and within 32 minutes, his temperature was down to 98 degrees. Next slide. So I thought this was interesting. These are the two temperature curves. The first case is the one using standard procedures until the star, and then they use the body bag. The second one, they immediately used the body bag and it dropped the temperature. And getting the temperature down quickly is really important for keeping the person alive. So I thought that was an interesting new development for emergency room or emergency department workers. Next slide. These are some of the presentations to the emergency department, 300 patients in Australia, behavioral disturbance. Often what gets them into the emergency department is their psychosis. They're acting out, their hyperactivity, they're ranting and raving and seeing things, hearing things. But they often, over half of them have tachycardia, 42% have severe hypertension, and 5% have this hyperthermia. Next slide. Next slide. They used olanzapine and Valium as the strategy for bringing down their activity level. And really, the goal in the emergency department is just to calm them down and keep them from hurting themselves or someone else. Next slide. I wanted to just mention that as I was talking about earlier, this is a tough group to engage in treatment, and so you need to have a full array of low barrier services for the people who aren't yet interested in treatment or haven't gotten, and we haven't developed this area as well as we have for opioid users, but certainly syringe exchanges are very useful. Naloxone, now that we're seeing so much fentanyl, and sort of places for them to cool down and clean up, it can be very useful. Next slide. This just makes the point. This is a syringe exchange program in the state of Washington. 82% of the individuals who were using opioids and getting their syringes for using opioids said, yeah, sometime I'll probably have to stop use or reduce my use or get into treatment. For those who are the methamphetamine, individuals who used methamphetamine, it was less than half. Again, you see this differentiation between the opioid users who think that maybe it's a good idea to get some help and stop using at some point. Those who use methamphetamine, less so. And so the harm reduction resources will need to stay very available to this group because many of them are not going to be interested in getting into treatment. Next slide. Yes, and you have a poll there that you can look at on which of the following approaches has the most robust evidence for treatment of individuals with stimulant use disorder, MI, CBT, 12-step, contingency management. Okay, you already know the answer. So I can go ahead. Yes, it's contingency management. I'm going to go quickly through this because these, I'm almost out of time, but also the data are overwhelmingly robust on this. There's very little question about this. Next slide. There have been, next slide. There have been, I think, 7 meta-analyses or systematic reviews of psychosocial and behavioral treatment for people who use cocaine and methamphetamine, and they all say the same thing. Next slide. This was one done by a group at Oxford University in London. Next slide. And the people who do these studies are not addiction experts. They're analysis experts. They look at these big data, these big junk piles of studies, and they sort out from all these studies, what's the punchline? Their punchline, after looking at 50 studies with 12 different interventions, is that the combination of contingency management and community reinforcement approach was the most efficacious and acceptable treatment, both in the short and the long term. Next slide. This similar thing done by the Corcoran Group in Europe and South America. Combination of different types of behavioral interventions showed results in favor of treatments with some form of contingency management in respect to both reducing dropouts and lowering cocaine use. Next slide. Mike Farrell and group published in The Lancet, which is a prestigious British journal review. Psychosocial interventions other than contingency management have weak and non-specific effects, and there are no effective pharmacotherapies. So the Australians say basically contingency management is the only thing that works. Next slide. This was published earlier this year. This is in Drug and Alcohol Dependence, 44 studies. While contingency management interventions showed the strongest evidence, there was some data for tailored CBT alone and with contingency management. So this one, again, says contingency management has the best data, but CBT has some data. Next slide. This group, these authors just looked at 27 studies, and they were all studies that used contingency management interventions for the treatment of methamphetamine using individuals. Next slide. Methamphetamine was reduced in 26 of the 27 studies. The people who got contingency management were retained in treatment longer. They attended more therapy sessions. They had higher use of other services. They reduced their risky sexual behavior, and they had increases in mood, positive affect, and decreases in negative affect. So contingency management doesn't just reduce their drug use. It also has these other benefits. And this is talking about contingency management alone, not with a whole array of other services or other, a package of stuff. It's the technique on their methamphetamine use. Next slide. You can go to the next slide. So currently, what we have is this contingency management has by far the best evidence. CBT has some evidence, community reinforcement approach has some evidence, although best when combined with contingency management. Motivational interviewing, although it doesn't have a lot of evidence for the treatment of stimulant use disorder, it's essential for working with hard to engage patients. They should just put it in the drinking water of all treatment efforts. And I've just published some data, about 8 papers after a big study on physical exercise as having benefit to individuals with methamphetamine use disorder. And I think it's one of the most promising non-pharmacologic approaches we have. It's the one thing I ever saw that helps with anhedonia. It helps them with that low mood that often results in them dropping out of treatment because they just can't see the reason to stay in treatment. Next slide. Okay, we're going to go through these quickly, just for those of you who don't know what contingency management is. Next slide. It is simply the systematic delivery of positive reinforcement for desired behaviors. In the case of treating methamphetamine dependence, vouchers or prizes can be earned for methamphetamine-free urine samples, or you can use it to reward attendance at treatment. There's a whole procedure that goes along with contingency management that is simple enough to use, but it's a very powerful technique. Next slide. Next slide. This was in twice. Next slide. The 3 challenges to the use of contingency management. Let's start with the bottom. There used to be a lot of staff resistance to the idea of using incentives. That many of the older staff, to be honest, I'm 72, so I can say that people were older, didn't like the idea of using incentives. People shouldn't be getting rewarded for doing what they should do anyway. They should be stopping their meth use, and I don't think they should get a prize for stopping it. So that was one big area of resistance of getting contingency management used. I think that's less now than it was 10 years ago, because I think as these stimulant problems have become more severe, people are saying, well, if it works, maybe we should consider it, even though we don't kind of like the idea. But if it works, it works. So that's one thing I think that's getting better. Secondly, moving up to the middle bullet is, where does the funding come? Well, as the secretary mentioned, these SOR grants, this last round of SOR grants, you can use funds from SOR grants to build a contingency management program. However, the big issue right now are Medicaid regulations. There are federal Medicaid regulations that I can't go into the whole story of them. There was a New York Times article about this about a month ago. It's called the anti-kickback rule, where giving incentives to patients who are in treatment with Medicaid can be viewed as a kickback. And it's a long story, but they have agreed to use of $75 per patient per year can be used. That's not enough. The studies in general used in the range of $500 over a 12-week treatment episode. So $75 really doesn't give you enough to do real contingency management. So that's one of the challenges the biggest challenge we have right now to the use of it. Next slide. I said exercise. Next slide. We did this study with 135 individuals using methamphetamine in a residential program. Half of them got a 8-week, 3-time-a-week exercise protocol. The others got a class that they went to. Next slide. Go a couple more slides. Next one. Okay, this is what we found. Go back to for those in the first 100 days of meth recovery, exercise improved their physical conditioning, not surprisingly. They didn't gain as much weight as they often do in residential care. Their cardiovascular functioning was improved as measured by heart rate variability. They had less anxiety and depression, and these were big changes in anxiety and depression. They were far less. This is that anhedonia stuff that we're talking about. Their craving was reduced. Their craving was about cut in half. We're just publishing that paper right now. We did PET scans on them at pre and post discharge, and we saw that dopamine system recovery was much more rapid with those who are exercising. So exercise, it's not just a good thing, like, you know, the Surgeon General says everybody should exercise. For individuals who have been using methamphetamine, it has specific benefits that I think are noteworthy and are measurable. And when people completed their residential treatment and went out into the world, there was a lower relapse rate among those who had received the exercise as part of their treatment. Some of them continued the exercise, obviously, when they went out into the world, but even if they didn't, their relapse rate was lower in the first year post treatment. Next slide. Medications, next slide. I spent much of my career at UCLA doing medication studies, and I think I have the record for being an author on the most negative studies. But we do have two candidates that are promising. Bupropion, or Wellbutrin, has a couple of studies that have suggested some benefits in helping people with mood, helping people start to clear their thinking more quickly, and using less drugs in a 12-week trial. The one that has just had a second randomized clinical trial with positive results is mirtazapine, or Remeron. This is another antidepressant, and this one seems to also have some real benefits. And then the others, there's positive and negative findings on use of those. I do have to say, when I've talked to the doctors who have used these with individuals who use methamphetamine, they have some benefits and they use them off-label. They're doing that, but they will say it's not like giving an opioid, individual who uses opioids, a dose of buprenorphine or a dose of methadone. It's not like they take this and they go, oh, I feel better. I can now go to therapy. I can now function better. It helps a little, and we're still in an early stage. I don't think anything is close to being ready to go to the FDA. So this has been a long, my first study I published on this topic was in 1981 on, I looked at imipramine for the treatment of meth use disorder. So that was the first of my negative studies, and I have a whole array of them on my CV. Next slide. I just want to close with this. The secretary mentioned the matrix model. The matrix model is something I wrote with a couple of my colleagues in the 80s, and it then was picked up by SAMHSA. We ran a study. It got some positive results, and it's been used around for the last 30 years. People ask me now about the use of it, and it's fine, except that it's 30 years old, and it's missing 30 years worth of new knowledge about what we know about stimulant use disorder. And so when I've been working with a number of states, West Virginia, California, Montana, about helping them develop treatment, one thing led to another, and they said, can you help us put together the evidence into a protocol? And I didn't want to because I'm trying to retire, but I broke down, and this is what we developed, this thing we've called TRUST. Next slide. And I see my time is just about up. So it includes the $75 of motivational incentives that we can currently use. If that gets increased, that should be increased a lot. So it's a full contingency management approach. CBT, CRA, motivational interviewing, and physical exercise. Those are all the components of this. Next slide. We've written it into a 12-week manual, and it's really we focus on retention, retaining these people in treatment, using the evidence-based ingredients. And we're making this available to people at no cost. There's no obligation. If anybody wants a copy of this manual, we send it out to people and they can do whatever they want with it. We haven't tested this manual. It hasn't been, but all of the elements have evidence to support them. We've just combined them into this one 12-week, twice weekly treatment program, which clearly is just the start of treatment. 12 weeks isn't enough, but it's sort of like a starter pack of treatment interventions. Next slide. So this is the data. I actually got it done by the time the red light went on. A lot more new research, behavioral treatments, including contingency management, and we have no medications. Next slide. Questions, and I think, is there one more with my email on it? There is not. Oh, there you go. That's my email. If you're interested in getting a copy or any of your questions that you have, you can send to me, or I don't know, Mary, should they send questions in to you and then you send them to me? Either way, I'll answer your questions if you send them, and I'll send you a copy of the electronic copy of the manual and workbook if you'd like it. So thank you very much.
Thank you very, very much, Dr. Rawson.
That was a lot of
Yeah.
stuff.
Not sure why we were having that. Thanks again for that very insightful presentation. We really do appreciate that. Very quickly, as a reminder, the questions that you submitted during Dr. Rawson's presentation will be answered and distributed to everyone. And this now ends Plenary 1. We'll take a short break now, but please remember, well, and since we went over just a hair, we're going to begin promptly at 10:15, okay? Plenary 2, again, will begin at 10:15. Thank you very much.